Our third session is on reprocessing of dialyzer. What is this reprocessing of reprocessing? I'm confused. Thankfully, we have with us Dr. Thiagarajan Thandavan to enlighten us. He completed both his UG and PG training in renal science and dialysis technology from Sri Ramachandra University, and he also done an MBA in hospital administration. Dr. Thiagarajan sir has completed PG diploma in medical law and ethics and PhD, and has several more degrees to his name. He is the visiting professor of SRM and Manipal and Vinayaka universities, and he is the member of Quality Council of India and ISO certified lead auditor and NAB's assessor. He is the guest speaker for many national and international conferences in the industry, and has trained more than 3,000 dialysis professionals from SAARC countries. Currently, he is the founder and CEO of TIDES Institute of Health and Medical Sciences, LLP, Chennai. Welcome, Dr. Thiagarajan sir, and over to you.
Thanks for your kind words, sir. So I would like to share my screen. Thanks for your kind words. I thank the organizing committee for giving this wonderful opportunity, and Dr. Anurag for giving this opportunity to enter and do the presentation on reprocessing of dialyzer. Coming to the reprocessing of dialyzer, basically what I understood in the system of reprocessing of dialyzer is infection control. So basically, we should understand what is infection control means. Then we will be good in doing the dialyzer, because the reprocessing dialyzer play an important role for the overall clearance during the dialysis. So generally, people think dialyzer reuse is a very easy technique or something which is not followed properly, which will create complications or.
Sorry to interrupt.
Yeah.
Can you make it a full screen? Put it on a slide so more.
It is in a full screen only, sir.
No, it is in the presentation. No, not in the presentation mode.
Is it? Mm-hmm. 1 second, sir.
Sorry for the technical glitches.
Now it's in the full screen?
No, not in the full screen. I think you can stop share and then again you can come with the screen sharing options.
The slideshow is not on, I think.
Yes.
Now it's correct?
No.
Now it's
so can I do it from my end, sir?
Now it's okay. Please.
Yes, it's fine.
Okay. So next slide. Next slide. Yeah. So looking into the priming of dialyzer, basically it's like sometimes in Indian scenario, 100% it's a dry dialyzer used to come. So the air needs to be removed out, which will need to be filled with a normal saline. So that is a basic understanding about the dialyzer priming. So when you're talking about a dialyzer reuse, we need to do the dialyzer priming perfectly. So that makes a lot of better quality outcome of the dialyzer, and clearance also will be perfect. So next slide. So the basically understanding of a concept is air is the death to the dialyzer. That means if any air is present inside the dialyzer, so that means the dialyzer, the total surface area is going to come down in the dialyzer. So we have to remove the air before starting, before connecting to the patients. Next slide. So the overall, the priming, when we say into the thing is we have to do the priming with the 100 to 150 ml per minute. In India में अभी देखने से उन लोग को ब्लड फ्लो स्पीड एकदम 200 और 300 भी रख के उन लोग को प्राइमिंग कर सकते हैं. So in India they used to do the priming at the speed of around 200 to 300 ml per minute also. Actually, when we are doing a priming, we should not cross more than 100 to 150 ml per minute. Even if the patient is sick, even if the patient is going to get a complication because of not starting dialysis, we should not do the priming at the speed of 300 to 400. Because if you do the priming, is basically 1 minute of the procedure.
Gloves का pyramid by WHO, मतलब कहाँ पे sterile use करना है, कहाँ पे use भी नहीं करना है.
So the priming speed we need to create around like 100 to 150 ml per minute. This will give a basic outcome of the dialysis quality outcome, and the membranes will be more and more intact, and more pores will be open. Next slide. So basically during the priming, if you increase the speed of priming, the air will start to enter, more and more air will start to enter. So that is the reason for it's called as an air block phenomenon. So in this technique, we have to keep the very low speed. So even if the air is coming from the blood tubing, actually we should not connect all the dialyzer tubing and then start the saline, because the most of the dialyzer are a gamma sterilized or a UTO or maybe in a steam sterilized. Now you are passing the air which is present in the blood tubing that will pass into the dialyzer. So generally the saline which needs to completely enter out of the, we have to remove the air from the tubing, then connecting the dialyzer. From the dialyzer, the air should comes out. While coming out, you can connect the second line of your venous line and everything. So that's the way the priming should be done. But majority all dialyzer will be tubings are connected and saline lines are connected and speed will be kept up. So this will make a residual of ETOs or a residual in the ETOs will be there in the dialyzer will be there, but not a major complaint, not a complication still, but long-term complication we can see. Next slide. And never touch the while fiber being filled up. So most of the time people have a habit of dialyzer, it will start like if before entering also we'll start tapping the dialyzer for removing the air. By the time it will shakes more and more air bubbles will form. Next slide. Yeah, this is the way the air more and more will form. Again, next slide. So sometimes they use the different types of material to remove the airs. It's always better keep a very low speed of a blood flow rate and remove the air, and most 199% of air will comes out. Next slide. Most of the time people think that the air in the dialyzer, they thought like after starting dialysis, we can remove the air. So if you do in that way, we can see this much of air bubbles in the compartments, or sometimes it will be in the venous compartment. If it is in the venous compartment, generally it goes to the venous chamber. But if it's there in the arterial chamber, unnecessarily these air enter into the dialyzer, and this air, you have to remember, this air completely move from the arterial header to the venous header. So once the blood and air mixes together, there's all this particular air where it is entering to the membrane, that whole membrane will be get clotted. So why the membranes are get clotted? Only because of the air in the dialyzer, and it is mixed with the blood and everything. So we have to be very careful even turning the or changing the position. आप लोग dialyzer में होने के time dialyzer में air कुछ आने remove कर दो, air पूरा को remove करता है. Remove करने के बाद you start connecting the patient. நீங்க இது பண்ணலனா, நீங்க air remove பண்றது இது சரியா remove பண்ணலனா, and the whole membrane it will get a block. So be careful with the priming. Priming is a major for getting into the release. Next slide. So this the air will blocks and not allow the any blood to follow through the crossing to the membrane, and clot will be formed. Next slide. So sometimes you can see this type of air bubbles will be forming. Even when the fistula is very poor, if it is less than flow rate of 200 or 180 or 150, better put the catheter. Don't dialyze the patient with the same AV fistula needle. You are going to compromise the quality of the dialysis. Never ever do the dialysis with the blood flow if the patient have a poor fistula or something. It's wasting our money and their time, their life and everything. So maintain a good AV fistula blood flow rate. Minimum, it should not cross less than a 200 ml of blood flow rate. Next slide. And priming speed, if you're keeping a priming speed of more than 350 ml, you can see how the blood flows will be happening into the system. So you have to be very careful in those areas. Next slide. So already I told the speed of the blood flow rate, if it is less than a priming speed like 150 ml, you can see the very good flow will be happening. Next slide. So if you are keeping more than 200 ml, you can see the flow of the speed, which is rising in a different membranes. So ultimately the air bubbles will be more chances of forming. So air bubbles will be more and more formed, means unnecessarily these will be trapped inside the membranes. Next slide. So even for the blood also, when you are connecting the patient blood line, even the blood is connected to the lines and then connected to the membranes and the dialyzer. So the flow should be kept very slow at the rate of 100 to 150 ml in the beginning. After that, you can increase the speed to even 300, 350, 400 ml also. That's not a problem. Next slide. So minimum residual blood loss at the end of the dialysis, you want to get it. So most of the time, we can see you can see a lot of blood will be there even after retaining the blood. This is all because of the air is present inside the membrane. So better we have to be very careful to reduce the residual blood loss at the post end of the dialysis. Next slide. So coming to the dialysis reprocessing, it is basically everyone knows rinsing, reverse ultrafiltration cleaning, and fiber bundle volume. Maintaining the fiber bundle volume play important role is priming, and using a right disinfectant helping your dialysis membrane to be very quality, very hygienic also. Next slide. Next slide. Yeah. So what is the previous slide? Yeah. Water rings for the blood compartment. Generally, water rings for blood compartment is most important. You should have a maximum pressure of 15 to 20 psi. Better don't cross more than 15 to 20 psi. And a maximum flow rate should be 1 to 2 liters. And most of the time, if it is done manually, we used to keep our own pressure to the membranes and for cleaning purpose and all. Generally, membranes have a capacity to attain a very huge pressure also. But the flow for a maximum flow rate should be minimum, it should be kept at, because forcing or something, we don't know, any particles may enter into the header of the compartment, and unnecessarily we may not know all those things, and it will be there permanently as a foreign body inside the dialyzer header. And the water rings in the dialysis compartment, that is a dialysate compartment, maximum it should be like a 1 to 2 liter and pressure of 15 to 20 psi. And the rings it and step next step. So already I told you 15 to 20 psi, and flush it properly, and then you can go ahead with the next step of your after the water. Next one. Yeah. So dialysate also you are cleaned, and also now finally coming to the reverse ultrafiltration, you are keeping your dialysate fluent and back and everything. Next slide. I can show you some of the practical. Next slide. So this is the blood compartment cleaning. This is the blood compartment cleaning. And only the blood compartment, while you are cleaning, you are removing all the blood clots and stains and everything inside the membrane. Next slide. And you are connecting to the dialysate compartment. Now again, you are removing all the residuals present, especially the urea content or a sodium content, which is a dialysate contents you are removing off. So you are clearing the dialysate compartment. Next slide. And when you're keeping a pressure on your dialysate compartment, giving a pressure to the membrane. So from your dialysate compartment to your blood compartment, some amount of RO water goes inside and cleans the, give a pressure and remove the pores which blocks, which is there. So from dialysate, you are giving a pressure to the blood compartment side to remove the residual blood presence. Next slide. So most of the time, membrane collapsed fibers is mainly because of the air. So I told you better to do the priming at the right speed. So next slide. So now finally you are cleaning the blood compartment. This is basically you are doing only the water wash right now. Use a proper Hansen connector, because in India, every tier 1, tier 2, tier 3 cities where you will have a corporate, major centers, they will have their own reprocessing machine. When you are gone to the other tier cities, the 2 tier or 3 tier, they may not have that reprocessing. So you are going to do the manual. So manual need to be performed in the right way to have a better quality outcome of these membranes and everything. Next slide. Next slide. Yeah. So disinfection filling is the most important thing. Either you are cleaning, after cleaning, disinfecting, it should be properly filled and it should be slowly filled, and you have to see how much you have removed the air presence in the membranes, that is a blood compartment. So slowly you have to fill and remove all the air which is present inside the blood compartment. Next slide. Hydrogen peroxide. Generally, it's used for your dialyzer disinfectant. That is a dialyzer cleaning. That is, you have to fill it in the dialyzer compartment and remove the blood from the clots from the blood compartment and start slowly move. So generally, hydrogen peroxide should be filled only in the concentrated hydrogen peroxide should be only filled in the dialyzer compartment. And most of the time, we can see that it will be syringe. With the syringe, they will be loading into the blood compartment. So when more blood or more clot is there, we should not use the direct hydrogen peroxide in the blood compartment. Next slide. So peracetic acid is a general disinfectant, which is a better, which is used for a cleaning purpose, and also you can use it as a disinfection also for the dialyzer. Next slide. Next slide. Yeah. Peracetic acid you can use in rightly properly prepared disinfectant, and there is a concentrations are available 2%. For every 2%, you should use 100 ml of peracetic acid, and remaining 4,900 ml will be your RO water. So that is a dilution purpose for cleaning. And same for when you are using your for a disinfection, it will be 175 ml of you have to take it for a further dilution for the disinfection purpose. Next slide. So bleach is generally used for your blood tubing reprocessing, but generally sodium hypochlorite is not a good content. It generally erode the membrane, erode the inner wall of the blood tubing. So there will be more chances of clotting and everything. So, and some of the RBCs will be, once if you are using a sodium hypochlorite high concentrated, so the membrane, blood tubings will have a lot of erosions and the softness, and during these areas where the RBCs will be adhered to those areas. So better not to use sodium hypochlorite for your next slide, for your blood tubings, and even don't use it for a dialyzer membrane also. Sure, no one will be using. Next slide. Formaldehyde. So formaldehyde still in India, some 25 to 30%, still we are using the formaldehyde, which will be comes in 37 to 40%, but the minimum concentration which will be kept at 4%, and the minimum dwell hour is for 24 hours. And most of the time, this formaldehyde usage is a very dangerous, very, and it form a formation of antigen like antibody, and even transplantation patients will have a complication for during the transplantation procedure. And formalin, instead of formalin, we have to go about the peracetic acid. That will be the future where the quality outcome also will be very good. Next slide. So better avoid the formalin. Please stop it. Next slide. Yeah. So the factors affecting the reusability of the dialyzer is most of the time inadequate anticoagulants are given. Most of the time I have seen how to reduce the clot. That is a major. When you are doing the reprocessing, everyone knows what we do reprocessing. But how to reduce the clot in the dialysis membrane or in the tubing means anticoagulation usage. Most of the time we use the 10 ml syringe for the loading the heparin. But in my understanding, after the few studies, I understood 20 ml syringes are the perfect for the dilution. Take a 20 ml syringe, dilute in a, if you're taking 1 ml of a heparin, dilute with the 19 ml of a normal saline, make a good amount of a volume dilution. And most of the time, when you're using a syringe pump, try to see whether all your machine syringe pumps are working. If your syringe pumps are not working, you will have a more chance of dialyzer clotting and more chances of because most of the time, if the pump is not working, we'll do the manual push. But most of the time, we forgot to push the heparin. And due to that, there will be more chance of clotting. And you can see the patient hemoglobin or other complication for doing the reuse also. And the patient quality of dialysis also won't be there, only because of the syringe pump and usage of the 10 ml syringe. So go see, and all machines syringe pumps are working, along with the, if it is not working, at least the manual push should be in the right time. So that is the most important for the anticoagulation usage. And membrane